retroversion of uterus. Now another position of the uterus is the retroverted uterus. Now what is retroversion? Is normally position of the uterus is anteversion. Anteversion and anteflexion is the normal position of the uterus. That means the uterus is bent forward. Now when the uterus goes backward, when it is bent backward, then we call it a retroverted uterus. Here in this picture you can see the retroverted position of the uterus. This is the normal anteverted uterus. See, this is the bladder, pubic symphysis. This is the rectum and anal canal, and this is the vagina. So this is the normal position anteverted uterus. It is bent forward. Now this is the mid position, and this is the retroverted uterus where the uterus is bent backward. Now again these pictures also show you the retroverted uterus. This is the normal uterus. You can see this is the pubic symphysis, urinary bladder, uterus, endometrial canal, cervix, vagina, and this is the rectum and anal canal. This is the vaginal introitus. Now you can see the direction of the vagina also. The vaginal axis is directed backwards and upwards, and see the uterus, it is bent forward. Now this is the retroverted uterus. Again same thing, see how the uterus is here and how the uterus is here. It is backwards, bent backwards. That is the retroverted uterus. Now what is the cause for this retroversion? Many times we don't see any cause for the retroversion. What we say, idiopathy. Now you see this in 20% of patients, and they don't have any symptoms. Only when the retroversion is causing symptoms and the patient is examined by the gynecologist, retroversion is found. Why the uterus is normally anteverted and anteflexed? Because it's inherent in the nature of the uterine myometrium, the direction of the muscle fibers, you can see the direction of the arrangement of the muscles, whatever it is. It is normal, it is inherent in the and also the position of the ligaments, fascia, etc. Because of all multiple factors, uterus is anteverted and anteflexion flexed. Now this retroversion, we call it a mobile retroversion and fixed retroversion. Now mobile retroversion is where the uterus is not fixed. It is not attached to the surrounding tissues. It is not fixed. There are no adhesions. So though the uterus is retroverted, it can always be moved. It can always be moved to the anterior position. Now this is associated with many times you see associated with the prolapse. Now what is a prolapse of uterus? I don't know if you are aware of it, if you had a class on prolapse, but prolapse of the uterus is where the uterus and cervix have descended downwards from their normal position, and the descent is so much that the cervix not only descends in the cervix, comes in the vagina, comes to the introitus of the vagina, but also outside the introitus. And when you see examine the patient, just one look at it, you can see that there's a mass protruding from the introitus, and the patient's complaint will be a mass per vagina. So in this case of uterine prolapse, first the uterus becomes retroverted and then it descends down. An anteverted uterus cannot descend. So the uterus bends backwards or at least gains the mid position and then it comes down. So mobile retroversion you will see associated with prolapse. Now also it may be associated with tumours like anterior wall myoma and ovarian cyst. See a myoma, you know what is a myoma? It is a tumor from the muscle tissue of the uterus, and this is if this is present in the anterior wall of the uterus, what happens is the uterus becomes heavier and this large fibroid in the anterior wall pushes the body of the uterus to backwards, because of its weight. So when it goes backwards, uterus, it becomes retroverted. Similarly, if there are large ovarian cysts are there, just by their physical presence, they push the uterus because the ovarian cyst is occupying the entire pelvis. Say huge ovarian cyst, say, which is 20 centimeters in diameter. Naturally, it occupies the entire pelvis and then pushes the uterus backwards. So when it is associated with tumors like myoma and ovarian cysts, there may be a retroversion. Then in the puerperium also, uterus may become retroverted. In the puerperium, the uterus is quite big. It is big, congested. Whatever the myoplasia, muscle hypertrophy that was present in the pregnancy is still present. Uterus is slowly getting involuted. Immediately after delivery, I told you the uterus is, fundus of the uterus is at the level of the umbilicus, and then slowly it gets involuted, becomes smaller and smaller, and then it becomes a pelvic organ. So now for all these changes to occur, it takes some time, no? So approximately about 3 months it takes for the pregnancy changes to regress. So in this period, uterus is still large, it is heavy, and so uterus may become retroverted if it falls backwards. But then, after the puerperium passes off and all the changes regress, uterus regains its normal size, and the muscles of the abdominal wall, perineal muscles, they regain their tone, normal tone. Then there may be a spontaneous correction. Uterus may spontaneously become anteverted. See, what is the normal position of the uterus? I told you it is anteversion and anteflexion. And it is anteversion and anteflexion. Now, what is anteversion? What is flexion? First, basically, you must know what is version, what is flexion. The uterine body, I told you, is bent forwards at the junction with the cervix. Now, the relationship of the direction of the cervical canal to the direction of the vaginal canal, vagina, that is version. That is how the cervix is placed in relationship to the vagina, that is version. Now, what is flexion? Flexion is in the way the body of the uterus is bent on the cervix. This is at the junction of the body of the uterus and the cervix. So it is relationship between the direction of the uterine canal and the direction of the cervical canal. That is flexion. So first flexion, then version. So flexion is at the level of the junction of the uterus and the cervix. Version is the relationship between the cervical canal and the vaginal direction. Okay. So normally the uterus is anteverted and anteflexed. See, anteflexion and anteversion usually go together in 99% of the cases. So if you just remember version, anteversion, that is enough. So when the uterus is anteverted and anteflexed, what is the direction of the cervix? The cervix is directed posteriorly, in the sense that it is the posterior, the anterior lip is more lower than the posterior lip, and the posterior lip is facing the posterior fornix. In a retroverted uterus, the cervix is directed forwards. That is, the anterior lip is facing the anterior fornix. Now, when you do a pelvic examination, a vaginal examination, how to diagnose the version is to see the direction of the cervix. If the cervix is directed posteriorly, it is a normal anteversion. If the cervix is directed anteriorly, it is a retroverted uterus. That is one of the features for diagnosis. This picture clearly shows you the version. See, this is the pubic symphysis, again bladder, uterus, this is the vagina. You see the direction of the vaginal canal. Now you see this is the direction of the cervix, cervical canal, and this is the uterine. Now, so this is the flexion. Flexion is, this is flexion. This is flexion. Okay, junction of the uterus and the cervical canal. Now this is version. This is version. See the cervix, how it is directed? It is directed posteriorly towards the posterior fornix. So this is the anteverted normal position of the uterus. See, this is the mid position where the uterus is going to become a retroverted one. It is almost straight and the cervix is directed downwards. And you see, this is the retroverted uterus. You see the cervical canal, that flexion is there. See, flexion of the uterus on the cervical canal is maintained, but then the version is different. See, the cervix is facing more anteriorly, like this. See how it is facing here and how it is facing here. Okay, now what is fixed retroversion? Fixed retroversion is conditions where the uterus is fixed, the position of the uterus is fixed, it cannot be moved. It is difficult to correct this retroversion. Why it is fixed? Because to the surround there is disease around the uterus. Around the uterus, in the pelvis, there is disease. See, in mobile retroversion, there is no disease around the uterus. It is defect is only in the uterus, so it can be corrected. But here in fixed retroversion, Sandhya, I'll call you later. I'm in the class, okay? And then మళ్ళీ వచ్చేస్తాను. క్లాస్లో ఉన్నాను, లేదు క్లాస్లో ఉన్నాను. Okay, so fixed retroversion is because of the disease around the uterus, it is fixed. Now, what are all the diseases? There are adhesions or there are tumours around the uterus. Now, various diseases particularly in the adnexing, pelvic inflammatory disease, pelvic endometriosis, then chocolate cysts of the ovary. Chocolate cysts of the ovary you see in again pelvic endometriosis, where the endometrial tissue is there present on the ovary, and then the endometrium, it forms a cyst filled with chocolate colored fluid. I don't know if you had a class on endometriosis, but all this is endometriosis is nothing but ectopic endometrium. Endometrium normal position is inside the uterine cavity, isn't it? In the lining the uterine cavity. But when it is present outside the uterine cavity, we call it an ectopic endometrium, that is a pelvic endometriosis. So in this condition again, because of the presence of this ectopic endometrium, adhesions form from with the uterus, appendages with the ovary, fallopian tube, pelvic peritoneum, then all the ligaments. So everything becomes adherent, and so in these conditions, PID, pelvic endometriosis. And then again in malignancies also, where the disease has spread to the surrounding tissues, to the parametrium, and say cervical carcinoma or endometrial carcinoma or even ovarian carcinoma, everything becomes fixed because of the presence of the cancer tissue. So in all these conditions, the uterus is fixed in the retroverted position. So here it is difficult to correct the retroversion by simple measures. Here it needs extensive surgery or treatment for the primary disease which has fixed the uterus. Like you have to treat the endometriosis or the pelvic inflammatory disease or the cancer for treatment of the for correcting the retroversion. So what symptoms does the patient come with? What are the symptoms? Are usually related to the etiological factors which have caused retroversion. Particularly in cases of fixed retroversion, the disease process, the primary disease process, the symptoms of that disease are present. Like, say it is endometriosis. Endometriosis, there may be polymenorrhea, irregular menstrual cycles, or excessive bleeding, And then there is severe dyspareunia, pain during coitus, excessively severe. Even a pelvic examination causes severe pain for the patient. So, or it may be a case of PID, pelvic inflammatory disease, where you may palpate some large masses. Patient complains of infertility, again polymenorrhea may be there. Yes. Then suppose it is malignancy, such as cervical carcinoma. She may complain of irregular bleeding per vaginum, pelvic pain, white discharge or blood-stained white discharge. All these symptoms may be there. Here, all these symptoms are the symptoms of the disease which is as causing the retroversion. And here, so particular symptoms related to the retroversion may not be there. So, what are all the various symptoms that a patient with retroversion can complain of? Dysmenorrhea. Dysmenorrhea may be both congestive and spasmodic, particularly in the fixed retroversion. Now, you all know what is dysmenorrhea. Pain during menstruation is dysmenorrhea. You all know that. And you know the types of dysmenorrhea also. Congestive, basically two types, congestive and spasmodic. There's one more type, what we call membranous dysmenorrhea, which is not common. But congestive and spasmodic. What is congestive dysmenorrhea and what is spasmodic dysmenorrhea? Congestive dysmenorrhea is where, because of the congestion of the pelvic organs, where the blood supply is more, venous engorgement is there, venous stasis is there. So, in these conditions, how do you differentiate this congestive dysmenorrhea? This dysmenorrhea starts a few days before the actual onset of menstrual bleeding. 2 3 days before the onset of menstrual bleeding, and then once the bleeding starts, this becomes less. As the bleeding proceeds, the pain also disappears. That is congestive dysmenorrhea. Now, what is spasmodic dysmenorrhea? Spasmodic dysmenorrhea is where the uterus is contracting, uterine muscle is contracting. So, this usually starts after the start of the menstrual bleeding. Here, this is because of the presence of some tumors in the uterus, or presence of, then there is more amount of bleeding, presence of large clots, and uterus tries to expel these clots. Or say a polyp is there in the submucous myoma, which has become a polyp. Uterus is trying to expel it. So all this, because of the contraction of the uterus, there is spasmodic dysmenorrhea. So both these types of dysmenorrhea are seen in retroversion, and particularly in the fixed retroversion. Then menorrhagia, excessive bleeding during menstrual cycle, menstrual bleeding is present. It is in fixed retroversion. It is because of the pelvic congestion. The associated disease, there is more blood supply, and so more congestion and causes the congestive dysmenorrhea. Then in mobile retroversion, it may be because of myohyperplasia, because that hyperplasia of the myometrium, or it may be DUD, that is where the hormonal imbalance is there. The HPO axis, there is derangement of this HPO axis, and then hormonal imbalance, and that may be causing the menorrhagia. Then pressure, usually pressure symptoms are not major. Pressure symptoms are more only if there is associated tumor in the fixed retroversion. Say a large ovarian cyst is there, or a large fibroid is there, that may be causing a pressure. But otherwise, there is not much pressure in a mobile retroversion. There is not much pressure on the rectum or on the bladder neck. But if there is associated tumors, then say the cervical fibroid is there, or a fibroid in the anterior wall of the uterus, presses on the urethra, then retention of urine may be there, or irritation of the base of the bladder, increased frequency may be there. So, like that, only if there is associated disease, pressure symptoms will be there. Backache. Backache is complained of by many women with retroversion, but here again, the back ache may not be related to retroversion. It may be because of the primary disease that is present. Okay. Then dyspareunia. Dyspareunia, pain. You all know what is dyspareunia. It's pain following coitus, and this pain may persist for 12 to 24 hours also. That is for one day also. This pain may persist following coitus. Now, why does this occur and when does this occur? If both mobile and fixed retroversion, it may be there. Fixed retroversion, additionally, because of the disease, say endometriosis is there, it's a very painful condition. So, it is more because of those conditions. But even in mobile retroversion, the dyspareunia is there because the uterus is falling backwards. See, when the uterus is falling backwards during coitus, the more pressure is there on the uterus. And so, and if there is uterine tenderness, say myohyperplasia is there, or congestion of the uterus is there, uterus becomes tender, that is painful. It becomes painful. So, because of the pressure, then pain increases. Or because of the retroversion, the ovaries are also carried backwards and they prolapse into the pouch of Douglas. When you do a pelvic examination, you can feel in the posterior fornix, the ovaries can be felt. Now, so this prolapse of the ovaries into the pouch of Douglas, now intense pressure on the ovaries, yes, then that causes a lot of pain during coitus. So, dyspareunia is present in both types of retroversion. Then abortion. The abortion retroversion may not directly be a cause for abortion, though it has been mentioned many times. The cause may be because of the associated condition. For example, if there is a fibroid polyp is there, the uterine action is more, uterine contractions are more. Then, while it is trying to expel the polyp, even the implanted ovum may be expelled or embryo may be expelled, causing abortion. So it may be more related to the associated conditions rather than the retroversion itself. But what we see is infertility, which can be explained because of retroversion. That is more present than abortion. Patient may not become pregnant rather than becoming pregnant and aborting it. Now, infertility. Why infertility may be present in a retroversion? Because I told you in retroverted uterus, where is the cervical canal directed? Cervical canal is directed anteriorly. So the cervical os is facing the anterior fornix. See, during coitus, the semen is deposited in the posterior fornix. So all the sperms are there in the posterior fornix. And normally in an anteverted uterus, the cervical os is directed towards the posterior fornix. So the sperms gain entry into the cervical os, into the cervical canal, and then they ascend along the uterine canal to the tubal ostia and go to the fallopian tubes. And there in the fallopian tube, where the ovum reaches the fallopian tube and fertilization occurs. This is what occurs normally. So normally, when the cervix is directed posteriorly towards the posterior fornix, the sperms can easily gain entry into the cervical os. But here in retroverted uterus, the os is facing anteriorly. So the sperms that reach the anterior fornix and then gain entry into the cervical os. So that may be one of the reasons for infertility in retroversion. Then you can detect this by doing the Sims-Huhner test. That is what we call post-coital test. After coitus, within 2 hours, the cervical mucus from the posterior fornix and also from the cervical canal is obtained, and on a slide, it is spread on a slide and then examined under the microscope to detect the presence of sperms. Now, if sperms are present in the cervical mucus, then it means that the sperms have gained entry into the cervical canal. If there are no sperms in the cervical mucus, but sperms are present in the vaginal pool, then it means the sperms have not gained entry into the cervical canal, and that may be one of the factors in causing the infertility. Yes. Then in a retroversion, a fixed retroversion, additional factors are there, like tubal block may be there, anovulation may be there. See, endometriosis, ovaries having chocolate cysts, or the chocolate cysts are present on the posterior fornix or in the peritoneum or on the uterosacral ligaments. All this, may be associated with anovulation. Ovulation may not be occurring in the ovary. Then also say PID is there, or even in endometriosis, tubal block will be there because of the presence of the adhesions. The tube gets kinked, it gets pulled this way and that way. So, and then in PID, even intratubal adhesions will be there. Endosalpingitis may be there, and so the intratubal adhesions will be there. So, because of the tubal block, then sperms cannot reach the ovum cannot reach the sperms, or ovum may not be picked up by the fimbral end of the fallopian tube. So many things can occur if PID or endometriosis or even malignancy are there. So in fixed retroversion, those factors play a role in causing infertility. So many causes are there for infertility in retroversion. So how do you diagnose this condition? How do you diagnose retroversion? You diagnose by noting the direction of cervical os on a speculum examination. You can actually see the cervix where it is directed, and you can confirm it by your bimanual examination. The os is directed anteriorly, cervix is directed anteriorly, and the uterus has become posterior. And your bimanual examination, you can detect other conditions also, other associated conditions. Like say an abscess is there, a hydrosalpinx is there, or a pyosalpinx is there, or a TO abscess is there, or an ovarian cyst is there. All this can be diagnosed can be felt by your bimanual examination. And then tenderness of the uterus can be detected. And if the uterus is very tender, you can think of an associated endometriosis particularly. So your examination, clinical examination, helps you to coming to some conclusion about the diagnosis. So when there is a retroverted uterus, how do you treat this? Treatment: asymptomatic mobile retroversion, no treatment. Because this was detected only because you have done a pelvic examination for some other reason, maybe as a general checkup or whatever reason, and you have detected that the uterus is retroverted. But the patient has absolutely no symptoms. So when there are no symptoms, is there any need to treat any condition? No, there is no need to treat, because a mobile retroversion without any associated additional disease is not going to cause any harm in the future also. Particularly if the patient is fertile and she has had one or two children, then absolutely no need to treat this patient. You treat when it is symptomatic, when there are symptoms like back pain or menorrhagia or other symptoms, dysmenorrhea, whatever I have already described, or when it is a fixed retroversion. Then in this case, how do you treat? You not only try to fix the uterus anteriorly, but you also treat the associated condition. The treatment basically should be directed towards the cause of the retroversion in fixed retroversion. Here, you're not going to treat the retroversion isolated manner. Your treatment of the retroversion is only secondary. And once you treat the primary cause, many times the correction of the retroversion also gets included in that. So there may not be any special need for correction of the retroversion if you treat the primary cause. Or at the time of treatment of the primary cause, say, for example, it's a case of pelvic inflammatory disease. There is a hydrosalpinx or a pyosalpinx or a tumours. So you do a laparotomy, you remove the pyosalpinx or hydrosalpinx or the tumours, and at the same time, you also do some sort of surgery to keep the uterus in the anterior anteverted position. Those surgeries I will tell you now. So, as a part of the treatment of the primary disease, you also correct the retroversion. That is in the symptomatic case, and that particularly in a fixed retroversion. So, pessary test. Many times, if there is no particular primary disease, many times the patient complains of symptoms like particularly back pain. Back pain is a very common symptom. Low back pain by a woman is a very common symptom. And incidentally, you have found that this patient has a retroverted uterus. This uterus is not fixed. There is no other associated disease. And any other cause for the backache you are unable to find. See, a backache may be because of some lesion, some disease in the spine, in the vertebrae, or in the local belly, or in the gastrointestinal system, the rectum, the anal canal. So, but you are not able to detect any other cause. Now, here you want to know whether this retroversion is causing the pain. That means, is the pain because of the retroversion? Otherwise, see, if you treat the retroversion in this patient and that is not the cause for pain, then the pain won't be relieved, isn't it? It will be an unnecessary treatment, unnecessary surgery for the patient without any relief from the pain. Now, only if the retroversion is causing the pain, then only she'll be relieved by correction of the retroversion. So, to know this, if retroversion is causing the pain, you do a pessary test. Here you keep a pessary in the vagina, particularly the Hodge pessary. It's not like a ring pessary. It's not round. It is more like a oblong. It is oblong shaped. This Hodge pessary. This is kept in the vagina across the vagina. See, the posterior edge of this pessary is fixed against the sacrum posteriorly in the posterior fornix, and anteriorly it gets fixed against the pubic bone, that is in the anterior fornix and anterior bone. It rests across the vagina like this. So when it rests across the vagina, and it is pushes the cervix backwards, so that the uterus comes forward. That means with this pessary you're correcting the retroversion temporarily. This is only temporary. Please remember. So you are correcting this retroversion, making the uterus in the anterior position. And this stays in the anterior position because of the presence of the pessary, Hodge pessary. Now, so what you do a bimanual examination with your fingers, manipulate the cervix and the uterus, bring the uterus forwards, that is, correct the retroversion, and then put the Hodge pessary. And this Hodge pessary will then retain this uterus in the anteverted position. Leave the pessary for 3 months, and then ask the patient to come back. And when the patient comes back, you remove the pessary, and then you examine her after a few days. Now, if symptoms are persisting during the period when the pessary was in place, then what does it mean? In spite of the pessary, in spite of the correction of the retroversion, the symptoms are still there. It means that retroversion is not the cause for the symptoms of backache and other symptoms the patient is having. So you have to look for other causes, and the correction of retroversion is not going to help this patient. But if she was in this period, in this 3-month period, if she was relieved from symptoms, and then after removing the pessary, the symptoms come back, then that means the symptoms are because of the retroversion, and this patient, you are justified in correcting the retroversion surgically. Understand? So this is called the pessary test. Right. See, this is how the Hodge pessary is there. You can see this is the Hodge pessary. This is shaped like this. It is placed across the vagina. This is the vagina, bladder, pubic bone, uterus, uterine canal, cervical canal, anal canal, and the rectum. So when it is placed like this, the anteversion is uterus got corrected. This is now the anteverted position. The pessary is holding it in place. Right. So surgery. When we do surgery, what are the indications? One thing I told you, if pessary test shows that the symptoms are because of retroversion. Then in fixed retroversion, along with surgery for the primary lesion, you also do a shortening of round ligaments. See, I told you the example, you remove in PID, you remove the hydrosalpinx or pyosalpinx, and then the round ligaments, you shorten the round ligaments, That means the round ligaments in retroversion, what happens is because the uterus moves backwards, the round ligaments go from the fundus of the uterus towards the inguinal ligament across the lateral wall of the pelvis, isn't it? So this, because now the uterus has fallen backwards, these round ligaments get stretched. Round ligaments are going anteriorly, so they get stretched. So when you correct the retroversion, you also shorten these round ligaments. So you placate these round ligaments. So along with the surgery for the primary lesion, you do this. Then suppose you're doing a tuboplasty or you're removing the myoma, the large myoma is there in the anterior wall, you remove that. Then again, you don't want this uterus to fall backwards. Here, many times what happens after surgery for the primary disease, the uterus again falls backwards, becomes retroverted. Then what will happen? This uterus, say a myoma was present in the fundus or in the posterior wall of the uterus. You have made an incision on the posterior wall and you have removed the myoma. This myoma, this uterus also has myohyperplasia. After surgery, it may fall backwards and then become adherent to the posteriorly to the pouch of Douglas, that is to the peritoneum in the behind the uterus. Now, if then that will become a fixed retroversion. Now, if this becomes fixed, what happens is the direction of the fallopian tubes, the direction of the cervix, everything changes, anatomy changes. And if myomectomy was done basically for improving the fertility in this patient, the whole purpose is lost. The tubes get kinked, again the problem of infertility will persist. So here, to prevent the retroversion, we do surgery along with like a plication of round ligament or other procedures which I will tell you are done following the tuboplasty or myomectomy. So only these are the various indications for correcting the retroversion. Now, what are all the procedures that are done for correction of this retroversion? Ventrosuspension. This is a modified Gilliam's operation. We call it. Gilliam's was the one who devised this. It was modified slightly and now it is called ventrosuspension. Here, the round ligaments are fixed to the anterior rectus sheath. I told you the round ligaments pass towards the inguinal ligament, isn't it? So these round ligaments are brought retroperitoneally towards the above the inguinal ligament into the beneath the anterior abdominal wall, that is between the peritoneum and the rectus sheath of the anterior abdominal wall, like how we do fix suspend the uterus in prolapse of the uterus. See, all those who said, I don't know if you had a class on prolapse, you can understand, where we just suspend the uterus uh, by fixing the ligaments to the cervix and then fixing to the anterior rectus sheath. So here the round ligaments are used, they are fixed to the anterior rectus sheath. So by this you're shortening the round ligaments, tightening the round ligaments and pulling up the uterus forwards. See, the round ligaments are attached to the fundus anteriorly. So you're pulling the uterus forwards and correcting the uterine retroversion. Then another procedure is the plication of round ligaments. That is, the round ligaments which are long, which have become stretched out, you shorten them. How? Plicating them. That is, just take a simple suture through the round ligament, like tacking. I don't know how many of you know stitching, but in school we used to be taught with this tacking. You take a thread and just straight stitch you put. So, and then when you pull it, it becomes like a frill, isn't it? So, like that, you plicate the round ligament with a non-absorbable suture. If you put an absorbable suture, the suture will get absorbed within 1 week or 10 days, and then round ligament will go backwards, isn't it? So, non-absorbable sutures, with that, you plicate the round ligament. That means you're shortening this round ligament, pulling the uterus anteriorly. Then you got the Baldy-Webster's operation. This is more like a more permanent one. Here, the round ligaments are passed through anterior and posterior leaves of broad ligament. Round ligaments are stretched, isn't it? So you make a hole in the anterior leaf and the posterior leaf of the broad ligament. You know the broad ligament has both leaves, anterior leaf. I will explain this to you when I was talking about tubal surgery, sterilizations, all this Irving's procedure, Uchita's procedure, and all, where the femoral end is or the cut end is placed inside the leaves of the broad ligaments. This is also something similar. So you make in a hole in the anterior leaf of the broad ligament, posterior leaf of the broad ligament. Take the round ligaments from its anterior position to behind the uterus, and then suture to the posterior surface of the uterus. Suture backwards. Fix it with non-absorbable suture to the posterior surface of the uterus. So that means you're shortening the round ligaments and tightening them so that the uterus is pulled anteriorly. So all these procedures you may have to do along with the surgery for the primary disease in fixed retroversion. If it is a mobile retroversion which is causing symptoms, say mobile retroversion only when it is causing symptoms, they will need all these surgeries. All these surgeries can be done for mobile retroversion only if it is causing symptoms. So these are the various